This presentation will be on CTA at the University of Mississippi Medical Center, though it should apply elsewhere as well. We're going to focus on obtaining the CTA and some of the limitations and advantages. So the patient comes in with the worst headache of their life, sudden onset. So what are we going to do next? Why? And what's it look like? We're going to do a non-contrast CT. It'll be quick, it'll be non-invasive, it's very sensitive in detecting hemorrhage. Subarachnoid hemorrhage will be hyperdense. So following this, we'll end up doing a CTA, and again, subarachnoid hemorrhage is hyperdense on CT, and 95% are positive in 24 hours. As you go out from that, the sensitivity will decrease. So the CTA is performed to evaluate the source of bleeding and potentially to figure out what therapy we're going to do, either surgical or endovascular. Seeing the aneurysm on CTA, it's going to depend on the images that we have for the CT examination, how they're reconstructed, what planes you're looking at. There are different things we can do. There are 3D reconstructions, there are maximum intensity projections or MIPS, and then shaded displays and volume rendering. So how do we perform a CTA? We use a helical CT scan. We get isovoxel images. That means we can reconstruct them in sagittal and coronal planes. As far as getting the contrast, we inject through the vein, we track the bolus in usually the aortic arch, and then time the CTA when the Hounsfield units hit the correct number. MIPS have certain limitations. Anything with hyperattenuation will show up on a MIP unless it is removed. Often the aneurysms will blend into the adjacent arteries, which can make it a little bit more difficult to figure out exactly where the aneurysm is arising. As far as the technique of getting a MIP, only the highest attenuation voxels get collected, and those are used to create the image. It makes 2D images where you get voxels from different locations within the targeted volume, but it's all shown in one plane. And in that case, you can't really tell if something's forward or backward on the single MIP image. Endovascular planning with the CTA, it can be used to predict how to approach endovascularly and what projection to get at that time. It can give you a better idea of the dimensions of the aneurysm to figure out what would be the best initial coil to use. Limitations of the CTA, there's a certain resolution limit, and so small vessels below, say, 0.5 millimeters are not necessarily going to be visible. These can be seen on angiography. It can be difficult to figure out if a dilatation is just an infundibulum at the origin of the vessel, or if it's an aneurysm, and that can lead to some false positive results. And that's why direct angiography will often follow a CTA. Additionally, the CTA, it may not be possible to see a clear margin between the aneurysm and the adjacent arteries, and that can make you think that there's a connection between these vascular structures when one may not exist. Additionally, with conventional angiography, you see contrast enter and exit the vessels over time. On a CTA, you have one single point in time, and you can end up with venous contamination, which can make it appear as though an abnormality is present when it isn't. Patients who have had aneurysms clipped previously or coiled, beam hardening artifact will make it difficult to visualize the nearby structures. In postoperative cases, CTA really is not very useful, and MRA with and without contrast would be a better way to evaluate those aneurysms. Other non-invasive studies we can do, I already mentioned one of them, MRA. MRA is the other non-invasive way to take a look at the vessels. So some of the advantages of MRA are that the bone is not going to cause artifact, and some of the dense coil material is not going to cause artifact. The disadvantage is that sensitivity of small aneurysms is less with MRA. Also, if there's a lot of patient motion, MR always takes longer to acquire than CT, so that could cause some trouble. As a recap, CTA is a useful tool in evaluating the intracranial vasculature. Looking at the different reconstructions and planes can help identify the aneurysm or vascular abnormality compared to just looking at the axial images. Once the abnormality is identified, CTA can help with the surgical or endovascular management. And in patients with prior aneurysm coils, MRA is going to be far more useful than CTA due to problems with artifact.